This week, we're going to be looking into the problem of cancer. There are questions at the end of the chapter that I hope students use to help review the material. The prevalence of cancer is quite significant in the United States, and the risk of contracting cancer in males is 1 in 2, and for women, it's 1 in 3. So in this particular chapter, I'm going to be covering the prevalence of cancer in the United States, the prevention of cancer, the pathophysiology of cancer, and I'm going to also be looking specifically at the assessment of cancer patients, looking specifically at metabolic changes that take place during cancer that help guide the assessment. And I'm going to be looking at the prognostic nutritional index, the PNI, and what it's used for, the patient-generated subjective global assessment as a method specifically of assessment. Then we're going to look at nutrition therapy. We're going to look at a case study of a patient with cancer. And again, as I mentioned, there are questions at the end of the chapter to help integrate the information you've learned in this chapter. The prevalence of cancer is imposing. The lifetime risk of contracting cancer in 2018, in males it was 40.9%, and in U.S. females 39.1%. And the costs associated with it, with the management of cancer, is overwhelming. In 2018, cancer costs the healthcare system an estimated $150.8 billion a year. The causes of cancer are intertwined with our lifestyle. Epidemiologists have been able to establish that 45% of cancer deaths in men and up to 59% in women have been tied to diet and lifestyle. Researchers have also shown that caloric restrictions appear to protect against cancer. Most notable were studies in the 1940s in rats that showed that caloric restrictions were able to hinder the development of tumor or mammary tumors. The use of antioxidant supplements in cancer prevention has been looked at and considered, and there are a lot of studies that demonstrate that either there's no effect or that the effect is actually worsening or worsens the cancer condition. So there is some precautionary measures that need to be taken here. So not so much the supplements, but rather the diets rich in antioxidants appear to be very protective. And this is certainly what we get from the Okinawa studies that have looked at the diet and the lifestyle of the Okinawa people and the longevity that these people are able to reach with very low disease rates. So there's a lot there that needs to be considered, but the use of supplements specifically don't appear to lengthen the lifespan of the individual or necessarily decrease the rate of appearance of cancer. If anything, it's innocuous, has no effect, and in the worst case scenario, it may actually worsen cancer conditions. So dietary strategies to prevent cancer are certainly considered a primary approach to dealing with the problem or the risk, not so much the amount of supplements that you take, but rather the broad assortment of foods that you include in your diet, with preference given to fruits and vegetables of various types, notably the cruciferous vegetables, the cabbage, the broccoli, the Brussels sprouts, etc. So these are really important considerations for the diet in order to prevent cancer. The pathophysiology of cancer can be broken down into essentially 3 basic steps: cancer initiation, cancer promotion, and the metastatic phase of cancer. So cancer initiation is something essentially that happens frequently in our body as we get exposed to carcinogens from the outside world. And so it puts at risk the integrity of the cells, but because we're able to basically be very resilient that is our body, we're able to counter a lot of these initiation phases. But the initiation phase takes place over many decades, and this is what essentially many oncologists claim, is that 20 years of exposure to a carcinogen could eventually lead to this cancer initiation leading to the promotional phase. And this is where we see the cells, the cancer cells, developing and proliferating and taking over the system, and then progressively moving towards a metastatic phase that involves basically the movement of the cancer cells to other organs in the body and overpowering these organs, and this becomes sort of a metastatic cancer. Read more about these different phases in your textbook. Colon cancer is the third most prevalent form of cancer in both men and women in the United States and responsible for thousands of deaths each year. Being able to screen for cancer, specific colon cancer, is very important. Here we see a graph or a pic of a benign polyp being removed from the colon of an individual. What we know about prevention of colon cancer is tied very much with this idea of being very focused on removing polyps as they appear. Polyps can be carcinogenic, or in other words, they can be malignant, or they can be benign. But even removing benign polyps actually decreases the risk of developing malignant tumors later on. So this is what we know about colonic polyps. They are certainly considered a pre-phase to cancer, so it's important to remove them. This is clearly understood. We also know that about 5% of colon cancers are actually genetic, that 20 to 25% are familial, meaning that they are found in family histories, but 75% are actually sporadic. The Sloan Kettering Cancer Center research that has come out in recent years found that 53% decline in cancer death rates when the polyps were actually removed consistently. So those individuals that are at high risk of developing polyps are those with a high fatty food consumption, high red meat or processed meat intake. It's found also in people that consume very few fruits and vegetables. And again, I like to put the emphasis on the importance of consuming vegetables of a cruciferous nature. Individuals that exercise little, smoke a lot, and drink excessively are also prone to developing polyps. Ductal breast carcinoma represents about 70% of invasive breast cancers, and it's the leading cause of cancer deaths in women. There are a few non-modifiable factors or risks associated with cancer, and I'll let you review these in the textbook, but I want to focus on the modifiable ones. Significant weight gain after the age of 18 certainly is a risk factor, and becoming overweight and obese, another risk factor. And then physically inactive lives associated with higher risk of breast cancer. When the intake of alcohol is 1 or 2 alcoholic drinks per day, that is associated with a risk factor, and the recent use of oral contraceptives is also tied to that. Now, delaying having your first baby till after 30 is associated with breast cancer risks. Now, breast cancer can metastasize to the lymph system. That's really dangerous. The survival rate, nevertheless, is 84% over 5 years. And when it metastasizes to organs such as, for example, the liver, 23% survival rate over 5 years. Now, the good news is that there's a 90% overall survival rate today, and if the cancer is localized, meaning that it hasn't spread, then the survival rate is up to 98%. Now, the assessment of cancer patients is a very important step. It allows the physician to be able to formulate an appropriate prognosis or likelihood of responding well to the treatment. Now, the assessment is complicated. It's a little irregular because of the metabolic abnormalities that take place in cancer. So, for instance, there's weight loss. There's an increase lipolysis, which is a breakdown of fat in the body. There's an increased proteolysis, which is an increased breakdown of protein in the body. And there's this increased glycolysis. In other words, the glycolytic cycle becomes heavily used, and this is called the Warburg effect. It's nicely described in your textbook, so be sure to read that. And of course, there's hyperglycemia, uh, and this is documented in the Cori cycle, which is also explained in the textbook. So make sure that you focus your readings on these two effects. So indeed, weight loss is a very important phenomena that happens in cancer. And we're going to take a little look at the body compositional changes that take place with weight loss. When a cancer patient loses weight, the patient loses a lot of body water. There's also a loss of body protein in the form of an erosion of organ protein, for example, and also in skeletal muscle protein breakdown. There's also a loss of adipose tissue or fat reserves, breakdown of abdominal body fat, there's a breakdown of thigh fat, and there's also a loss of subcutaneous fat. The overall result is a visible emaciation, or what we call cachexia, when the weight loss from protein and from adipose tissue is extensive. The next phenomena that's observed is increased lipolysis, or increased breakdown of fat or adipose tissue. Let's take a look at the implications and the process. In the cancer state, there's an increased secretion of TNF alpha, tumor necrosis factor. And scientists believe that the TNF alpha, as you can see in this particular picture, increases lipolysis or the breakdown of fat. And we also know that catecholamines also are very influential in causing an increased breakdown of the fat or adipose tissue. Catecholamines are secreted from the adrenal medulla and consists of dopamine, norepinephrine, and epinephrine. In cancer patients, the lipolysis or the breakdown of fat is consistent and persistent, and this is because of the unnatural makeup of the and function, if you will, of the TNF alpha and of the catecholamines, which are secreted in much higher concentrations and in a persistent way. The next abnormality that I want to look at is the increased proteolysis or breakdown of proteins. Before we take a look at the excessive and persistent breakdown of protein in the body, let's look at a normal homeostatic mechanism for protein. The idea of homeostasis in protein is tied to this idea of an amino acid pool, which we see as the central rectangle in this image. This amino acid pool is fed first from the dietary amino acids that we ingest with our food, and second from the protein breakdown or the proteolysis that naturally occurs, and that in a balanced state, it balances off, if you will, with the protein synthesis. So this means that in a homeostatic state, the body naturally breaks down protein and synthesizes protein in a balanced sort of equation. So in the end, there's no net loss of body weight or net loss, if you will, of body protein. The catabolic breakdown of the amino acid from the amino acid pool leads to a deamination, a removal, if you will, of the nitrogen from the amino acid to alpha ketoglutarate, ultimately leading to ammonia and to the eventual production of urea. So we see this particular reaction then on the right. So now in a catabolic state, we see an increased breakdown of body protein, and we see, of course, an exaggerated downward segment there for proteolysis, so an increased breakdown of the protein and feeding into the amino acid pool. And then we see little bit to the right, a greater and thicker segment there for catabolism. And this means that the amino acids that are in the amino acid pool are being broken down, and this is through a process of transamination. And this is where the amine group gets passed on to alpha ketoglutarate, and then on to ammonia, and then ultimately urea. Now, from a biochemical perspective, there is also an increased glycogenolysis, or an increased breakdown of glycogen. Well, what does it mean that there's an increased glycogenolysis? It means that the glycogen phosphorylase enzyme, its activity is increased, and it's breaking down glycogen into single glucose units, as you can see, from glycogen right to glucose 1 phosphate, and then down to glucose 6 phosphate. And we know that glucose 6 phosphate can then become glucose, and this in the liver. And this production of glucose then goes, of course, into the blood. So we see typically in this lack of food intake and the breakdown of protein and in the breakdown of glycogen, a rising of blood sugars in these patients. Dr. Otto Warburg, back in the 1930s, noticed that cancer cells reacted abnormally because they had an altered metabolism. The phenomena was essentially what he described was a faster aerobic glycolysis inside the tumor, which used a much higher than normal amount of glucose and generating, of course, very high levels of lactate. And the phenomena was later called the Warburg effect. So if we take a look at the glycolytic cycle as exemplified here, we can see how increased glucose utilization means a greater flow downwards of the glycolytic cycle, which leads here to greater amounts of pyruvate at the bottom, and from pyruvate to then lactate being the last step. So the Warburg effect is really an exaggerated glycolytic downward flux with a lot of glucose utilization, abnormally large amount of glucose utilization, and an exaggerated amount of lactate production. Another phenomena observed in cancer patients is increased circulating blood sugar, or hyperglycemia. So where does this hyperglycemia come from? Well, it comes from the endogenous production coming from hepatic glycogen reserves. So there's a certain amount, a significant amount, that comes from this glycogen breakdown. There's also a persistent gluconeogenesis, which catabolizes the protein in order to form glucose. So we have glucose coming from there. And researchers have also noted a persistent Cori cycle, which is really an inefficient recirculation of this lactate production we saw earlier with glycolysis, which then through the liver and through gluconeogenesis ends up in the production of glucose. This glucose then getting taken up by the muscle and then reverting back to lactate again with a net 4 ATP requirement. So it costs the system 4 ATPs to do this. So for that reason, it's really an inefficient system. It uses energy to actually produce this Cori cycle. Now I want to take a look at the normal regulation of glycolysis in starvation and in the well-fed state. This will help us better understand the metabolism during cancer. So first I want to look at what happens in starvation. In starvation, liver glycogenolysis increases. Insulin decreases. Glucagon increases. There's increased glucagon to insulin ratio, meaning a higher proportion of glucagon than there is insulin, therefore calling the body to produce sugar, and it does so through the glycogenolysis. There's also increased epinephrine that takes place as well, which leads to an increased release in glucose. The insulin decrease makes sense in light of the fact that there's less sugar. So, because there's less sugar, the beta cells of the pancreas secrete less insulin as a result. But by contrast, there's increased glucagon production produced by the alpha cells of the pancreas. And this causes increased glucose productions through the breakdown of glycogen or glycogenolysis. Now, when we look at the well-fed state, we see that glycogenolysis decreases. In the well-fed state, there's a lot of sugar, normal sugar in circulation, and so there's less need for sugar to be produced through the breakdown of glycogen. Therefore, um, there is a decrease in glycogenolysis. There's increase, however, of glycogenesis in the muscle and in the liver. Glycogenesis is the synthesis of glycogen. So in the well-fed state, the body is actually synthesizing more glycogen as opposed to breaking it down. So what we see then is increased insulin production, because you need that increased insulin produced from the beta cells of the pancreas to help glucose enter the cells. There is, by contrast, less glucagon because the body is not called to produce sugar because the sugar is coming exogenously through the food. There is a decrease then of the glucagon to insulin ratio, meaning that there is more insulin relative to glucagon. Glycogenolysis increases in exercising muscle, right? So this is a reality of muscle. So you can be in a well-fed state, and then in addition, with the exercising of muscle, there's a breakdown of glycogenolysis. So even though in the well-fed state glycogen does not break down in the liver, you can counter that process by exercising. And therefore, despite the fact that there is higher insulin and less glucagon, glycogenolysis in this case, can increase because of the effect of exercise. And this glycogenolysis is stimulated through the effect of epinephrine, which is really adrenaline, which naturally increases, of course, with exercise. So now, in contrast to the internal metabolism that we see in normal fasting and in basically feasting situations, in cancer we see an altered metabolism. So the first thing to remember is that cancer causes a persistent breakdown of both the protein and the fat, leading to, in many cases, extreme emaciation, which we call cachexia. Now, what about the story behind the actual fat? Well, there's a persistent lipolysis, or breaking down of the fat, because the cancer cells produce a lipid mobilizing factor, or LMF. This lipid mobilizing factor is unrelenting. Usually, in normal metabolism, when we eat, insulin levels go up and fat breakdown is actually stopped. But in cancer metabolism, this particular stopping of lipolysis does not occur. So in that sense, we say that the lipid mobilizing factor causes this persistent, unrelenting breakdown of fat. Well, what other anomaly? Well, in cancer, we see an increased metabolic stress taking place, and there is a increased secretion of catecholamines, which causes a lot of sugar to be produced in the blood through the process of gluconeogenesis. And there is also at the same time the production of insulin resistance. This is where the insulin that's produced isn't very effective in getting sugar to move into the cells. The consequence of this is high circulating blood sugar, hyperglycemia, which we saw earlier. Now I want to approach the subject of the assessment of a cancer patient. And there are two methods that I want to look at. First is the Prognostic Nutritional Index, the PNI, and the second is the Patient Generated Subjective Global Assessment, or SGA. So first, let's take a look at the equation. The PNI is equal to 158 minus brackets, then first parentheses, 16.6 times the concentration of albumin, ALB, in grams per deciliter. Next, plus another parentheses, 0.78 times the tricep skin fold, TSF, in millimeters, close parentheses, plus 0.20 times transferrin, that's serum transferrin concentrations, milligrams per deciliter, close parentheses, plus 5.5 times the delayed cutaneous hypersensitivity, so that's DH, with a margin there of possibly 0 to 2 as factors that you can put in there. So when we look at the PNI, then a PNI measurement that is greater than 50% represents a high risk of morbidity. So what the Prognostic Nutritional Index is doing is it's forecasting the likelihood of a good outcome. So high morbidity means high disease rates. A PNI of 40 to 49 is an intermediary risk of morbidity, and a PNI less than 40% is low risk of morbidity, or in other words, a brighter outlook as a forecast related to treatment or to disease process. Let's take a patient that has an albumin level of 5.1 milligrams per deciliter, a tricep skin fold of 13 millimeters, transferrin, serum transferrin that is, 200 milligrams per deciliter, and a delayed cutaneous hypersensitivity test that looks at the demarcations of the skin, the actual circling of the skin around the implantation of an allergen inside the skin. So it's a measurement, if you will, of skin reactivity to an allergen. So we have 2 right here as a measurement. So this is the profile of a typical healthy individual. I want to start off with the first line of the PNI, which you see has only parentheses but no brackets. So what you see is 158 minus 16.6 times the albumin minus 0.78 times the tricep skin fold minus the 0.20 times transferrin and minus 5.8 times delayed hypersensitivity. Now, once you put the brackets in, the minuses change to pluses. So it becomes 158 minus the summation of 16.6 times albumin, and again the summation of 0.78 times tricep skin fold, and so forth. So all the minuses get transformed into pluses. So if we place our numbers into the equation, we see the 5.1 grams per deciliter replacing the albumin, the 13 millimeters replacing the TSF, the 200 milligrams per deciliter replacing the TFN, and the 2 replacing the DH. Next, you complete the calculation inside the brackets, so 16.6 times 5.1, and then 0.78 times 13, and 0.2 times 200, and finally 5.8 times 2, and you add them all up, you get 146.4. You subtract that value from 158 and you get 11.6. So looking at the previous table, it's less than 40%, so it is indeed a low risk of morbidity or a low risk of complication and disease for that particular patient. So I would encourage students to practice this equation using different varied values of albumin, tricep skin fold, transferrin, and delayed hypersensitivity, and just become acquainted with it so that you don't have any difficulties completing this calculation during a quiz. Now I want to look at the patient-generated subjective global assessment. There is a copy of this particular table in your textbook, so I encourage you to follow along as I look at the various categories. So, according to this title of this assessment tool, it is indeed subjective. So, it uses clinical experience as well as some objective measurements to come up with some particular resolution regarding the prognosis or the risk of malnutrition. The first thing I'm going to look at is in the upper left corner, and it's the weight history. Notice that they're interested in the current weight, the usual weight, and in the percent loss, right? In the percent body weight loss. So, in other words, they're looking here at the current weight as a percent of the usual weight. So, if the patient has lost a certain amount of weight over a 3 month period, that leads to a certain prognosis. But if it leads to a greater percent, a more significant percent over 6 months, it also has other implications. And we'll see these more specifically when we look at the assessment more closely. And ultimately, the idea is what is the goal weight to achieve? So, in many cases, it's an idea of weight regain. So, trying to get the patient to put on some weight in order to be more successful in going through the cancer treatments. I want to provide you now with a profile of a patient that underwent some weight loss after the diagnosis of cancer. So the current weight is 140 pounds. The usual weight is 175 pounds. Now, the patient's weight 3 months ago was 155. 6 months ago was about 170 pounds. And ultimately, we want to measure the percent of this patient's usual weight. So we take the current weight relative to their usual weight, so that's 140 divided by 175 times 100, and we get 80%. What's our goal weight for this patient? Well, what we see here is that we want to keep unwilling or unwanted weight loss to less than 5% so that it'd be normal. So we want to bring this patient back to maybe a 4% weight loss under the 175 would be a pretty good goal, and that would be 168 pounds. So that would be our goal weight. Now, what we understand about the 80% can be viewed in the assessment guidelines under the subjective global assessment form. What we know from the form is that a patient is regarded as well nourished when they lose less than 5% of their body weight. When we look at moderate malnutrition, we can see that a mild to moderate malnourished patient experiences 5 to 10% of their weight loss over a 3 to 6 month period. And a severely malnourished person loses more than 10% over a 6 month period. So now when we do the calculation, if we take 6 months ago, the patient was weighing 170 pounds, so the current weight, 140 over 170, gives us 82%. So that means that over a 6 month period, this patient lost 18% of their body weight. That certainly puts them in the severely malnourished category because they experience greater than 10% body weight. The next section I want to look at is called diet assessment. This section is highly subjective because there's no clear calculation that you're doing, but really with this assessment of food intake, you're left with an impression of how the patient is doing. First, my food intake compared to 1 month ago. I'm eating more, I'm eating the same, or I'm eating less. So if a patient is saying that they're eating less, that's a first indication that overall intake is low. Next, the type of food that they're eating. A normal diet, very little solid food, only liquids, only nutritional supplements, very little food of any kind. So you can see that in decreasing order, the situation is getting more alarming in terms of what the patient is able to eat. So if they're eating less and they're only eating liquid diets, that tells you a lot about their ability to eat well, their ability to chew, for instance, or just their overall sense of well-being. Liquids are the only things that their stomach can tolerate. Very little food of any kind indicates advanced anorexia or loss of appetite, and that, of course, worsens their prognosis. The next section right under activity assessment is equally subjective. What are the daily levels of activity over the last month? Normal, less than usual, don't feel like doing anything, and I spend half of the day in bed sitting down or sitting down. So again, it's a sort of a descending order of importance and severity. Normal physical activity suggests normal ambulation, normal function, but less than usual is just a little less. But once they start talking about they don't feel like doing anything, there's a psychological component in there as well as a physical component. And of course, being bedridden seriously indicates that they are not functionally capable of moving around. So, a low functional capacity, although it has nothing to do with nutrition, certainly becomes a very strong prognostic indicator of well being over the future. Someone with low functional capacity does not fare as well as somebody with a much higher functional capacity. Now, the second column, called ability to eat slash tolerate food, is a section dedicated to get a little bit more understanding about the digestion and eating process. So it begins with the question, I have problems eating, yes or no? If the answer is yes, indicate below the problems that you're eating, that you're having with eating. So there's a whole set of little boxes that can be ticked off. Notably, I have no appetite, I have nausea, I have vomiting, constipation, bloating, diarrhea. Foods are tasteless, foods have a funny taste, I feel full quickly, I have problems swallowing, I have problems with my teeth. All kinds of different options that can be ticked off to help the physician and the dietitian understand the difficulties that the patient is having so as to be able to come up with a viable solution. The box at the bottom I have depression, I have money problems, I'm worried, I'm anxious, I'm nervous. And that, of course, is an opportunity to bring in psychology services in order to assess the capacity of that individual to manage the stress and the anxiety and the worries and help them relieve those anxieties as much as they can so that the therapy can move forward and be beneficial to the patient. So, in a severe situation, a patient could complain about saying, well, yes, I have problems eating, I have no appetite, I'm vomiting, I have nausea, I have bloating, I'm worried and depressed. These would all be very subjective um, criteria, but very influential in helping the physician come up with a prognosis for the patient. So, finally, the last section to consider is disease assessment and physical exam. So, in this section called disease assessment, the physician is identified the current diseases, the oncological treatments, oncology treatments, if you will, the other treatments that will be given to the patient, complementary treatments, um, the serum albumin level before the oncology treatments, the pre-albumin after oncology treatment. And these are actually very important. The albumin, even though it's a serum protein, is never considered as a protein status for the patient, but rather it's a very strong prognostic indicator, as you could see in the PNI calculation. A low albumin does not bode well for the patient's overall well-being on the long term. Now, this is important to take before the oncology treatment because you want to be careful. If the albumin is too low, the treatment protocol might be delayed. Now, the prealbumin after is really a reflection the recovery process. It's a much faster protein, shorter turnaround time, and it is reflective to a better extent than serum albumin of the protein recovery in the body. The column right next to disease assessment is the physical exam. So here you're looking at the body fat deficit. Is there one or not? Uh, if If yes, rate it mild to moderate to severe. What about the body muscle deficit? Is there a visible sign of muscle erosion or breakdown? If yes, mild to moderate to severe. What about edema? Edema is the accumulation of water in the peripheral areas of the body, notably the legs and the arms and so forth. Ascites is a central accumulation of water, usually in the peritoneal cavity. If yes, is it mild to moderate to severe? What about pressure sores? What about fever? And again, a reminder of the percent weight loss over 3 months, and then the percent weight loss over 6 months, and the current weight as a percent of the usual weight. All this considered then will help the physician decide on the assessment overall, whether or not the patient is well nourished, moderately malnourished, or severely malnourished. So we'll look at that in the final step of this assessment. So it would be helpful to memorize that a well nourished patient would have to have less than 5% body weight loss. In addition, the patient will not experience any loss of muscle or fat tissue. There's no observable gastrointestinal problems or symptoms, and the physical activity is pretty normal. Now, moderately malnourished, then we're looking at 5 to 10% body weight loss over 3 to 6 months. The patient will have a mild loss of fat and muscle tissue and will report having digestive problems, difficulty consuming adequate amounts of food. Now, that's moderately malnourished. The severely malnourished is more than 10% weight loss. There'll also be severe loss of fat and muscle tissue, a significant loss in physical activity or function, gastrointestinal problems, and usually edema in the extremities and possibly even ascites. Now, a serum albumin less than 3 is a good less than 3 grams per deciliter is a poor prognostic indicator and is tied to poor tolerance of treatment and poor survival, independent of the nutritional status. So it's very important to remember that. So what to remember? That well nourished, less than 5%, moderately nourished, 5 to 10% weight loss, severely malnourished, more than 10% body weight loss, and the serum albumin less than 3 grams per deciliter gives a very poor prognostic index. So here are a few things to consider. First of all, the degree of weight loss, the percent weight loss, is significant. If it's greater than 10% weight loss over 6 months, this represents a significant impact on the prognosis, right, leading to a poor prognosis. If it's greater or equal to 5% weight loss over 3 months, this is also not a very good indicator. The goal weight needs to be achieved, and usually we aim for a return back to the usual weight, or a little less than 5% under that usual weight is acceptable as well. Diet assessment reveals poor prognosis if very little food is consumed, if there's just some liquid food, if the patient isn't interested in eating. So that bodes very poorly. Activity level as well. So an ambulatory patient, that moves around, gives a good prognosis. A patient that's bedridden is a poor prognosis. What about tolerating food while vomiting and nausea and diarrhea? All lead to a poor prognosis. What about serum biochemistry? Well, serum albumin is important. We saw earlier that less than 3 grams per deciliter is a poor prognosis, but the truth is that if a patient drops under 2.5 grams per deciliter, this indicates a very poor prognosis. The physical exam should consider like the body fat percent. So less than 5% in men and less than 15% in women is a bad indicator. So gives a poor prognosis. If the fat-free mass, that's the lean mass, is less than 73% in men and less than 62% in women, this also is a poor prognosis. And of course, the presence of edema and specifically ascites, again, which is the central accumulation of water in the peritoneal cavity, that also leads to a very poor prognosis. So all these things need to be considered and discussed in a case, for instance, where a lot of these parameters are being measured. Now I want to go over how to calculate a percent body weight loss. So take out your calculators, grab a pencil and a few sheets of paper. All right, so here's the problem I want to do with you. A man's usual weight is 235 pounds. After 1 year of cancer, his weight is 178 pounds. And the physician wants to know what his percent body weight loss was over that year. So how to calculate the percent body weight loss? First, you take his current weight, 178 pounds, minus his usual weight, 235 pounds. Divide that by his usual weight, 235 pounds, times 100, and that leaves you with minus 24.26. So he's actually lost 24.26% of his original weight. At what percent of his usual weight is the patient after 1 year with cancer? So at what percent of his usual weight is the patient after 1 year with cancer? 178 pounds is current weight, divided by 235 pounds, his usual weight, times 100, leaves you with 75.74%. So the answer is he's currently at 75.74% of his usual weight. So these are two types of calculations that could be done by the dietitian in the assessment of the patient. Here's another exercise. Exercise 2. A man's usual weight is 198 pounds. After 1 year of cancer, his weight is 234 pounds. Calculate the percent body weight gain. So in this particular example, we use his current weight after 1 year, 234 pounds, and we subtract that from the usual weight that he was at, 198 pounds, and we divide it by the usual weight that he was at, times 100. So what we get is he actually gained 18.18% body weight. At what percent of his usual weight is the patient after 1 year with cancer? Well, he's 234 pounds now. You divide that by 198 pounds times 100. So he is at 118.18% of his usual body weight. So this again are two different expressions of the weight, in this case gained, and in terms of comparing it to what his usual weight is at. So this is what you should take note of, that in both exercise 1 and exercise 2, we are comparing to the man's usual weight. We want to know how much weight he gained compared to his usual, and we want to know, in the previous case, how much he lost relative to his usual. So the denominator in both cases is the usual body weight. In the first example, with a lesser weight, the actual weight minus his usual divided by his usual. And then in the second exercise, it is his current weight minus his usual divided by his usual. Now, let's take a look at the nutritional therapy, what we'd prescribe for a patient with cancer. So we would have, for nutritional support, oral supplemental feeding. That would be food taken by mouth. Enteral tube feeding. That would be liquid diets given through mouth or through other entries, notably through the stomach or through the duodenum, through the jejunum, or possibly in the ileum. All right, so these are particular tube entries for the liquid diet. And then the other one is total parenteral nutrition, which could also be peripheral parenteral nutrition, PPN, which is nutrition given through the veins. So remember the guideline that if the gut is not compromised and there isn't any inflammation or obstruction, oral supplementation or enteral feeding is certainly highly advocated. Now, TPN comes in when there is a compromised GI tract, when there's severe inflammation, when there may even be obstruction, possibly cancerous lesions, for example, then it would be best to give the bowel some rest and to go through PPN or TPN. Now, what about the actual content of the feed that we provide the patient? Well, for calories, they tend to be elevated, about 25 to 30 calories per kilogram body weight. However, the literature basically supports the idea that most patients actually underconsume, and we have some averages going at 22 to 24 calories per kilogram, and that also is acceptable. We don't want to overfeed the patient where they're so uncomfortable that they get sick, so it's important to sort of consider these guidelines. Now, protein will tend to be elevated anywhere between 1.2 to 2 grams per kilogram body weight. This is because there's a significant amount of protein catabolism or protein erosion taking place because of the cancer. And we get to see that as the body mass index increases, look at table 7.1 in your textbook, and you can see that the amount of proteins currently recommended for obese and for morbidly obese patients varies between 2 to 2.5 grams per kilogram healthy weight. So, in other words, for a patient that's obese or morbidly obese, it's best to calculate a goal weight for them that is healthy and then to calculate their protein requirements based on that weight. The same thing would apply for the calorie recommendation. So, you don't actually use their actual obese or morbidly obese weights, but really the goal weights. Now let's tackle cancer prevention and try to answer the question, do supplements actually work in the prevention of cancer? The study that attempted to answer this question was the alpha tocopherol beta carotene cancer prevention study in 1994. The researchers observed that there was no reduction in cancer incidences among the men who were receiving alpha tocopherol or vitamin E, so it had no effect. Unexpectedly, though, researchers observed a higher incidence of lung cancer among the men who received beta carotene than among those who did not. Now, this group was a group of smokers that had been followed prospectively by the alpha tocopherol beta carotene cancer prevention study group. A subsequent study in 1996 looking at carotene and retinol in cancer prevention concluded that those subjects who smoked and received beta carotene supplements were developing cancer at rates greater than controls. The cancer risk was elevated up to 6 years after stopping the supplements. In 1996, the beta-carotene and retinol efficacy trial demonstrated the same sort of worrisome results. Participants receiving the combination of beta-carotene and vitamin A had no chemopreventative benefits and had excess lung cancer incidence and mortality. The results were highly consistent with a cancer prevention study also in Finland involving a little over 29,000 male smokers. The Physicians Health Study 1, which was a 12-year primary prevention trial of beta-carotene supplementation for non-melanoma skin cancer, concluded that after they had followed 22,071 subjects over that 12-year period, those who were receiving 15 milligrams per day of beta-carotene supplements did not The study found that it did not affect mortality or cancer incidences in smokers and non-smokers. So here's a contrasting study that basically says that the supplementation remains innocuous. In other words, equivocal results, but certainly not harmful results. Now, the selenium and vitamin E cancer prevention trial that ended in 2008 was a multi-center trial. It involved 35,533 men who were randomized from 427 sites in the US, Canada, and Puerto Rico. So, what they found is daily vitamin E supplements taken alone over 5.5 years had no effect on reducing the incidence of prostate cancer and other forms of cancer in men 50 years or older. Subsequent follow-up in 2011 revealed that subjects who had taken the vitamin E supplement had 17% greater risk of prostate cancer than those receiving the placebo. Now, the Physician Health Study 2 um, basically concluded that those subjects who received two antioxidant supplements, 400 international units of vitamin E and 500 milligrams of vitamin C over 7.6 years, had no impact on a wide variety of cancer incidences. So this particular study, the Physicians Health Study 1 and 2, did not find any increased incidence of disease associated with the supplementation. It's important also to note that these supplements had no, shall we say, protective effect against cancer either. I want to draw your attention to the case study about cancer in your textbook. Well, this is a 46-year-old female, presents with no distress, with shortness of breath, fatigue, appetite loss, and progressive weight loss over the last 6 months, equaling 11.7%. There's a hemo-occult test is positive, and there's no melena or chest pain. What are the lab results? Serum hemoglobin is low. There's elevated liver enzymes, very low serum albumin, and elevated blood glucose. So this is a profile in terms of the lab report that we sort of expect in patients that do have cancer. Remember, the low albumin, certainly, and the high blood glucose, absolutely. So if we want to do a nutritional assessment on her, then we need to establish her resting energy expenditure. We're going to use the Harris-Benedict equation because the patient is hospitalized, and this equation is more sensitive to hospitalized patients. We're going to establish the activity factor, we're going to establish the stress factor, and we're going to determine from that the total energy expenditure. Now, if we go to table 7.3, we can get a look at her usual food intake record, and then we'll be able to go to 7.4 in order to look at the various calculations for energy expenditure, and you will note the Harris-Benedict at the very top. So establish the energy requirement using the Harris-Benedict formula. So here's the formula for a woman. So it's REE equal to bracket 665 plus 9.56 times the weight in kilograms plus 1.85 times the height in centimeters, and that's close bracket, minus 4.6 times the age. A formula that kind of resembles the Mifflin equation. So now if you plug the values in, that is the weight in kilograms and the height that we know in centimeters, then you'll get 665 plus 820.34, which is 9.56 times the weight in kilograms, and then you'll get 324.23, which is 1.85 times the height in centimeters. Then we subtract 4.6 times the age, which is 211.6, and we get roughly about 1,598. Now we select the activity factor, and the activity factor is found in table 7.4. It's a fairly large table down to the lower right. And we're going to use an activity factor, usually for hospitalized patients, they are bed bound, so we're going to use 1.2. And then the stress factor, we think conservatively, so to avoid delivering excess calories to the patient. So we're thinking here about 1.25. So when we take the REE of 1,598 times 1.2 times 1.25, we get 2,397 calories per day. One protocol that could be followed then is for the TPN to be administered to deliver 2,397 calories in order to prevent further weight loss. And now we need to determine the protein, the carbohydrates, and basically the number or quantity of fat to provide this patient with. Now, the reason we are providing TPN is very simple. We have a patient here with hemoccult positive stool indicating blood in the stool and a possible malignant tumor in the GI tract, so that's going to be confirmed by colonoscopy. The elevated liver enzymes reveal the possibility of metastases in the liver. This should prompt the physician to further explore the likelihood of referring the patient to surgery or for a liver biopsy. But for now, in terms of nutritional support, it would be wise not to feed by mouth simply in order to avoid any complications if there is indeed a cancer in the GI tract. So we want to give complete bowel rest and go TPN or possibly even PPN on the short term. Now, a second alternative to feeding the full caloric requirement of the patient, which is 2,397, there is in the literature a lot of significant recommendation to minimize overfeeding. And so the aim could be for meeting about 60 to 70% of the patient's energy needs. What about protein? Protein should be anywhere between 1.5 to 2 grams per kilogram body weight. We saw that previously. The carbohydrates could be at 45% of the calories, the lower end of a healthy range. And then from that, how then do we determine the fat? So if we decide to aim for 70% of her energy requirements, we'd be giving her about 1,678 calories. And again, this kind of protocol is really encouraged to avoid the overfeeding in TPN. Now, we determined the protein perhaps this way. We can use a 1.5 gram per kilogram body weight. So that ends up being 129 grams. So that's equal to 516 calories. And that's equal to 36.8% of calories. Next, we can aim for fat by keeping it within the 20 to 35% range, and it's probably advisable to probably keep it low at the lower end, so we'll put 20%. So if 36.8% of calories come from protein and 20% comes from fat, then when we add those two together, what is that? 56.8. Then the balance, that is 100 minus 56.8, leaves us with 43.2%, and that's how much carbohydrate we'd be giving the patient. So now I want to answer the question, why does this patient have high blood sugar? Well, first, there's abundant release of catecholamines during metabolic stress, and a cancer patient is under metabolic stress. So the catecholamines enhance the rate of aerobic glycolysis. This results in adenosine triphosphate production, or ATP. Catecholamines enhance glucose release both from glycogenolysis, or the breakdown of glycogen in the liver in particular, and from gluconeogenesis, the production of glucose from the breakdown of protein, and also, as we saw, lactate. Catecholamines also inhibit insulin-mediated glycogenesis, right? So these catecholamines prevent insulin from facilitating access of sugar to the muscles and for the production of glycogen. Consequently, hyperglycemia and hyperlactemia are the hallmarks of this metabolic response during cancer. So we call this the combination of the Cori cycle, which recirculates um, lactate and then reproduces glucose through gluconeogenesis, and really the Warburg effect, which we saw earlier on. So the Warburg effect really describes an enhanced, much faster glycolysis, resulting, of course, in large amounts of lactate. Now, just as a reminder, catecholamines are epinephrine and norepinephrine, and they're actually released from the adrenal medulla. Now, I want to remind students that there are questions at the end of the chapter, so please go ahead and do that, and remember that the answers are right after the references. So now here's a training quiz that has questions that will give students the opportunity to do some assessments with cancer patients. So in this problem, a patient presents with a serum albumin of 2.4 grams per deciliter, a serum transferrin of 150 milligrams per deciliter, triceps skin fold of 3 millimeter, and a delayed hypersensitivity of 0. Identify below the patient's PNI, or prognostic nutritional index. Pause here and do your calculation. Select your answer. The correct answer is E, 86%. Because the percent is higher than 50%, then we would actually regard this patient as high risk. Now, in this question, there's a 58-year-old female cachectic patient with a weight of 78 pounds, a height of 5'10". She is confined to bed, so her activity factor is 1.2, and is diagnosed with a severely aggressive cancer. She's given an injury factor of 1.6, see the table in your chapter. And the question is really to determine the patient's total energy expenditure. This is a hospitalized patient, so you'll be using the Harris-Benedict equation. Stop here, do your calculation, and select your answer. The correct answer is E, 2,046 calories. So a patient presents with a greater than 10% body weight loss in the last 6 months. The patient is also at 78% of his usual body weight. The patient reports not being able to eat in the last 5 days because of xerostomia and mucositis. The doctor's concerned that the risk of aspiration is mild to moderate, and a GI series confirms a gastrointestinal tract that is not compromised. Identify below the kind of nutritional support that should be provided. Pause here and determine your answer. Well, the correct answer should be E, C, and D. So the concern about aspiration basically means that you want to stay away from the stomach because there is a danger of aspirating from the stomach. So if you put in a nasoduodenal feed, that means that you're actually bringing the tube through the nose past the stomach into the duodenum. Or you can do a nasojejunal feed where, again, through the nose, past the stomach, past the duodenum, right to the jejunum. And in this manner, you can avoid, decrease the chances at least, of aspiration. In this question, we have a patient with cachexia, presents with a body weight that is 78% of his usual. Patient has lost 12% body weight in the last 6 months and has not been able to eat in the last 5 days. Patient has mucositis, xerostomia, and in addition, the physician confirms obstruction and a very high risk of aspiration. Identify the ideal form of nutritional support. Pause here, select your answer. So the correct answer would actually be A. Total parenteral nutrition. Nutrition through the veins is ideal here because we have the idea that there might be gastrointestinal obstruction, and we know that there are concerns also about aspiration if we were to feed through the nose, for example. So this particular choice is ideal. So I would encourage students now to prepare for the rapid response quiz, and you get that by basically reviewing a lot of the calculations, the PNI, the Harris-Benedict, and they'll still remain proficient with the Mifflin, the Carrier equations, and so forth, the interpretation of the information. So review that thoroughly so that you can effectively run through the rapid response without any hesitation. So here are a few key concepts that you need to know very well, and I like to say that you need to know it cold. First, the Harris-Benedict equation for the REE of hospitalized patients. Know the two activity factors that are there. Know where to find the injury factors. Know how to calculate the TEE using both the activity factor and the injury factor. The use of the injury factor, of course, is subject to interpretation. So either if I want to have a very precise answer from you, I'll give you the injury factor. But if I need you to to go through some kind of an assessment, and I'm watching what your reasoning is, then I'm going to expect you to come up with some kind of injury factor that's reasonable, but there is certainly a broad range of possibilities. The prognostic nutritional index, the PNI, is very important, so memorize this equation because it can be done quickly. Memorize the three ranges of the PNI score so that you can interpret it. Now, hyperglycemia in cancer. Know why this happens, explain the Cori cycle, and explain the Warburg effect. And finally, know how to calculate percent weight loss. Know the significance of the cutoffs for weight loss that's used by the patient-generated subjective global assessment form. So be very familiar with those.